Hi, my name is Jihyun Park. I'm a pediatric interventional cardiology fellow at UC San Diego Rady Children's Hospital, and I'll be talking about my recent publication on Sports Medicine Open last year on fine-tuning EKG interpretation for young athletes, EKG screening using Z-score-based analysis. As we all know, pre-participation examination is a standard thing that is done across the board for patients, especially the athletes who are collegiate at the collegiate level participating in sports to screen for any underlying cardiac conditions that could be detrimental for them. EKG is not routinely included based on the current guidelines or recommendations. However, a lot of the providers and facilities actually utilize it because EKGs tend to have higher sensitivity and specificity than history or physical exam alone. However, the providers often face the challenges once they have the EKG result because there are a lot of findings that are abnormal. However, we also know that the athletes have this constellation of findings called the athlete's heart that constitutes electrophysiological, structural, and functional cardiac adaptations that are not necessarily abnormal, but may be benign. Focusing on the electrophysiological findings or EKG findings, the common ones that are benign are bradycardia, prolonged PR interval, increased QRS voltages, incomplete right bundle branch block, first degree AV block, early localization, or some TF inversion in anterior leads. However, there are also borderline EKG findings that may need or may not need cardiology referral, including axis deviation, biatrial enlargement, or complete right bundle branch block. However, the ones that we really want to focus on are the ones that are concerning, especially if there are any EKG findings that are consistent with or suspicious for cardiomyopathies, including hypertrophic dilated cardiomyopathies or ARVC or non-convection cardiomyopathy, then we are more worried and we would need further cardiac evaluation. Or from the rhythm perspective, if we see any findings consistent with WPW, if we see long QT syndrome, Brugada syndrome, or advanced AV block, then there is a higher chance of developing arrhythmias. So these patients also need further cardiac evaluation. However, as I mentioned before, there are some borderline findings, and sometimes we see some subtle changes on the EKGs that not all providers feel comfortable about, okay, this is within the borderline or this is within an acceptable range, but it's still abnormal, so I would rather be safe and have them referred and be evaluated further. But what happens from that is that we get a lot of unnecessary evaluation referrals from providers out there for these athletes because of the abnormal EKGs. So the objective of our study was to compare the EKG variables of collegiate athletes to non-athlete control subjects and define the differences, and compare the EKG variables in collegiate athletes to Z-scored normative standards derived from the non-athlete controls, and define the portion of athletes with EKG variables falling outside the normal range of the age and gender matched control subjects. So this was a retrospective review of EKGs and medical records from Hawaii Pacific Health Medical Facilities and Rady Children's Hospital, San Diego. Patients were aged 17 to 22 years old between January 2014 and December 2020 and received an IRB approval. The athletes group consisted of those that were in competitive sports at University of Hawaii from 2014 to 2020. All these patients had screening EKG as mandated by the university, and they completed screening questionnaires. The controls were the patients had HPH and RCHSD with no known heart conditions. The EKGs were done for variable indications, including murmur, irregular heartbeat, bradycardia, tachycardia, syncope, dizziness, fever, etc. This is the screening questionnaire that the athletes had to complete. To just give a brief overview, it consisted of past medical history, the medications that they're taking, and if they have any history or current cardiac symptoms such as chest pain, syncope, palpitations, or shortness of breath, and underlying cardiac or non-cardiac medical diagnoses. And of course, it also asks about family history, which can be very important, especially when we're screening for cardiomyopathies. The exclusion criteria included those that were missing demographic information or those with known cardiac conditions or history of cardiac surgery, and the pregnant women were excluded. A lot of the patients actually have multiple EKGs, and in that case, for a single patient, only the first EKG was used for the analysis. And we used a standard 12-lead EKGs with standard voltage and standard speed. The different variables that we looked at included RR intervals, PR intervals, the QRS duration, and QTC, the different peak amplitudes of the different waveforms on the PRT axes. and the area under the curve for the different waveforms as well. And then we use the SAS and the SPSS for the statistical analysis. Now, moving on to the results, these are the demographic data. Looking at the control group, we had about 6,500 patients compared to the athletes where we had about 670 athletes. Of those, there is a pretty fair, equal distribution of the age group for the control. However, as we can expect, as most of the athletes fall within the 18 to 20-year range, that's where a majority of the athletes fell through. And then for the genders, there was about equal number of females and males in the athlete group, and there were more females in the control group. Now, just comparing the EKG variables and how they differ between the two groups, athletes and the controls, all the variables that are listed on this page had statistically significant difference between the two groups. So for the athletes, they had lower heart rate or PR interval. The athletes had longer PR interval. They had more rightward axis. They had longer QRS duration. The QT was slightly longer in the control group. However, the majority of the patients all had normal QT. And then the T peak amplitude and the area were all larger in athletes as well. And these EKG variables were all statistically significantly different between the two groups, including the SP, SQ, and R wave peak amplitude, and they were all larger in the athlete groups. When looking at the Sokolow-Lyon criteria, the voltage criteria for the LVH, the athlete group also had larger number, as we had suspected. Looking at the R prime waveforms, so the athletes actually had more incidence of R prime waveforms that could be more concerning for RBCD or IVH or right bundle branch block. There was about 23% of athletes that had this R prime waveform in V1, and about 17% of controls had the R prime waveform in V1. And overall, the athletes had longer duration, bigger area, and the larger peak amplitude of the R prime waveform than the controls. Now, looking at one of the key findings of the paper is comparing the z-scores for these variables. We define the z-score of -2.5 to 2.5 as normal range. For the athlete group, most of the findings between the two groups are statistically significantly different, and those include the heart rate, the PR interval, the T wave peak amplitude, and the R wave peak amplitude. And as we can see here, the heart rate, there was only a small number of athletes that had heart rate over 2.5 range, as we have expected, because the heart rate tends to be lower in athletes. The PR interval, there was higher incidence in the athletes that had PR interval outside of the range of 2.5. The T peak amplitude, again, the athletes had higher incidence of those with higher than a z-score 2.5 peak amplitude in T waves. And same thing for the R wave. There were higher incidence of athletes with having higher amplitude of the R wave than the control group. That was z-score more than 2.5. Now the focus moves on to, so who actually needed referral to cardiology and who actually ended up having pathologies? So of the athletes, of the 672 athletes who were included in the study, 83 patients actually required referral to cardiology. Of those, 59 were due to abnormal EKG, 20 were due to abnormal symptoms that they have reported, and 4 were because of both abnormal EKG and symptoms. 24 were unfortunately lost to follow-up, and 59 completed the cardiac evaluation. Of those, 8 actually did not get any echocardiogram based on the benign history and the physical exam findings. So 51 athletes ended up getting echocardiograms. Of those, 36, which is the majority, actually had normal echocardiograms. Only 9 patients ended up having LVH, and only 1 patient had pathologic diagnosis of hypertrophic cardiomyopathy. The 8 patients only had mild LVH that were not concerning for hypertrophic cardiomyopathy, and some other benign findings that we saw that was classified as abnormal echocardiogram that we saw in these patient population was ventricular dilation and dilated coronary sinus, which is pretty nonspecific. So I'm going to focus on the z-scores for the abnormal EKGs, EKG variables for these particular population of athletes that were referred to cardiology. As you can see here, median z-scores for a majority of these variables actually still fell within the normal ranges, with the exception of a few. The left axis deviation, the r-axis, the median z-score was -2.7 in this referred group. The p-axis for these referred group for low atrial rhythm had median of -4.12 for the z-score. And last but not least, the QRS, the PR interval for the athletes that were referred because of the first-degree AV block had median of z-score 6.52. However, again, majority of the patients, even though 63 patients were referred here with abnormal EKG findings, and it's more than the actual number that was presented on the previous slide because some of them had overlapping findings, only 15 had abnormal echocardiogram here. And we're going to focus on particularly on the patient population who had the EKG findings concerning for the LV hypertrophy on the next slide. So moving our focus to those that were referred to cardiology because of EKG findings consistent with concerns for possible LVH, only 3 patients had echocardiogram that was abnormal with mild LVH, and none of these patients actually had a true hypertrophic cardiomyopathy. And if we look at the Z-scores for different waveforms and different leads, for those 3 patients in particular that had mild LVH, this patient, and that patient, we can see that the Z-score was over 2.5 and only 1 leads for each of these patients, here and here. On the other hand, interestingly, there were some patients that had Z-scores that were more than 2.5, even in more than 1 leads, and these patients still had normal echocardiograms. Now, looking at the negative T waves and inferior lateral leads that led to referral to cardiology, which could also be found in hypertrophic cardiomyopathy, there was only 1 patient with mild LVH, and this patient actually had a pretty more prominent abnormal finding on the Z-score because the T wave Z-score is negative 5.9 on this patient on one of the leads, and he had 2 other leads that had Z-score that was out of the normal range. And I kind of wanted to kind of move on to our focus to then, okay, so it seems like Z-score alone also may not be the only thing that we can look at reliably to predict the incidence of LVH in this patient. So I compared, so what are the number of patients that we are picking up based on the standard Sophy-Low-Leon index voltage criteria for LVH versus the Z-scores. So you can see here, of the total of 672 patients, actually 191 patients had EKG that met the criteria for the LVH based on the standard Sophy-Low-Leon index voltage criteria. That's 28% of the patients. On the other hand, based on the Z-score, if we just utilize a Z-score greater than 2.5, there was 53 patients, which only consisted of about 8% of the total patients. So if we were to use both, there were only 5 or less than 5, only 4.6% of patients. And of those, only less than 0.1% of patients actually had LVH. So again, if we were to use only one criteria, it may not be as sensitive. However, if we utilize both, we can see that it could be a more sensitive screening tool. And I just wanted to briefly touch on that one patient that had hypertrophic cardiomyopathy diagnosis. This patient had EKG findings as above. So again, he had a very prominently different Z-score that was outside of the normal range. He had multiple leads that were outside of the normal range that could be associated with LVH. And this patient had confirmed finding of hypertrophic cardiomyopathy based on echo and cardiac MRI, and he had a genetic testing that was positive for mutation in MYL3 gene. So moving on to the discussion, so in athletes, 83% of athletes that were included in our study actually had all EKG variables within the normal range of Z-score from negative 2.5 to 2.5. And excluding those that were kind of in that mildly abnormal range of Z-score negative 3 to negative 2.5 or 2.5 to 3 for the EKG variables that were typically associated with athletes' heart, 10.6 patients, only 10.6 patients, 6% of the athletes had EKG variable Z-scores outside of normal range. And all the athletes who had normal Z-scores, there was no evidence of cardiac arrest or pathologies that were identified during the average follow-up of 6.5 years. So the conclusion and the discussion and thoughts for our study is that we can consider using these EKGs, even though they were derived from the normal control subjects, to utilize as a screening tool for athletes to kind of screen for any underlying cardiac pathologies. And combining the use of the voltage criteria for the LVH and the Z-scores for the EKG variables may be useful in determining the need for further cardiac evaluation, especially for the LVH. And the suggestions that we had in our group of authors is that if there's one or more variable with z-score of more than 2.5 or less than negative 2.5, we can consider echocardiogram for screening. On the other hand, if there are more than or equal to 3 variables with z-score outside of the normal range, or more than or equal to 1 variable with z-score that's very abnormal outside of the range of negative 3 to 3, then we can strongly consider cardiac evaluation for any underlying cardiac pathologies. Well, the limitations of our study is that it was a retrospective analysis and not every athlete had secondary screening with echocardiograms. There was some class imbalance between the athletes and non-athletes affecting the statistical analysis, and subjects in the control group were not excluded based on the level of physical activities. An acutely ill state for some patients in control group may have affected EKG findings. And only 6.5 years was the average follow-up rate data available for the athlete group, and only one patient had true pathology with hypertrophic cardiomyopathy. So the take-home points from our paper is that despite subtle differences in the z-scores of the EKG variables in athletes compared to non-athletes, majority of the athletes had EKG variables z-scores within the normal range, and all athletes with normal z-scores had no sudden cardiac arrest or death on 6.5-year follow-up. EKG assessment in athletes with z-scores may guide clinical decision-making for secondary screening and limiting unnecessary referrals to cardiology, and a z-score-based automated EKG screening may be utilized as a step for pre-participation screening for these athletes. And these are the references, and that is it for my presentation. Thank you so much for all your attention.